Hello, my name is Dr. Benjamin Maughan. I'm an assistant professor of medical oncology at the Huntsman Cancer Institute at the University of Utah. I specifically focus on genitourinary malignancies. I put up this title slide so that you can see our beautiful campus here in the fall time of the year that we've just gotten into. I'm always welcome to visit with any of you and give you a nice tour of our campus if you're ever out this way. Today, we're going to be talking about immunotherapy specifically for prostate and renal cell carcinomas, and I should say specifically prostate adenocarcinoma and clear cell renal carcinoma. And I've titled it a Panoply of Futuristic Therapies because I'm going to be starting with where we are today and then give a slight glimpse at the end about some interesting developments that we're heading with in terms of research. So here's my conflicts of interest slide. I'm an advisor and a consultant to a number of companies, as you can see here, and I've also received funding to do investigator-initiated or investigator-sponsored clinical trials from Exelixis, Bavarian Nordic Clovis, and Bristol Myers Squibb. And some of these companies do sell, like BMS, for instance, sells immune therapy drugs that we'll be talking about today, as well as Exelixis. So a couple of the learning objectives that I hope to accomplish today in our brief time together is to understand the optimal first-line therapies for patients with metastatic clear cell renal carcinoma, understanding the impact of cancer vaccines in the treatment of metastatic testosterone suppression-resistant prostate cancer, also called metastatic castration-resistant prostate cancer, and also define the optimal patient likely to benefit from one of these prostate cancer vaccines prevention. So theoretically speaking, that's what this slide is discussing. What are the characteristics of an ideal immune therapy? Well, first of all, it's going to have a high response rate. Second, it's going to have very durable responses. And ideally, that will also mean that it can cure patients even with metastatic disease, or I should say be able to cure even some patients with metastatic disease. Third, it has to be tolerable across a broad range of patients, such as those patients that have renal impairment, hepatic impairment, or perhaps even the elderly. And finally, it needs to be affordable. So some of the immune therapies that we have today meet a number of these criteria, although it can be argued not necessarily all of them. But these are the characteristics of an ideal immune therapy. And we're going to come back to a couple of these components as we go along. Oh, I think there we go. And this then would be characterizing some of those components into a model, if we can schematically diagram it, of an ideal immune therapy. As you can see, very few patients have primary progressive disease to the treatment. And the response lasts for a very long time, and perhaps is even, you can see this, what we call tail of the curve, and it leads to a cure. Again, robustly over a long time. Note, this is a progression-free survival curve and not an overall survival curve. And so with that in mind, let's talk a little bit about some immune therapies in the context of renal cell carcinoma. So the idea, I don't show any of the data here, but the idea of the efficacy of immune therapy really predated a lot of these trials that we're going to be discussing today. And it started in the cytokine era with high-dose IL-2 and interferon. The majority of those patients did not benefit from the treatment, but there was a small proportion of patients, somewhere about 5 to maybe 10% of patients, that would be cured with that treatment. But for the other 90%, they really derived no benefit from the treatment at all. But that really demonstrated that immune therapy can work for kidney cancer. And so lots of research later, we have the checkpoint inhibitors. And so the first trial that really demonstrated the value of these checkpoint inhibitors was with the Checkmate 025 trial, which was evaluating Nivolumab in the second-line treatment. So in this clinical trial, Nivolumab at 3 mg per kg was compared against everolimus as second-line therapy. It enrolled patients from 2012 through 2014. And there was quite a healthy number of patients that were randomized. The minimum follow-up at this initial presentation, that's what I'm showing you here, was only 14 months, and the primary endpoint was overall survival. And so as you can see from the overall survival curves, it was better than everolimus with a hazard ratio of 0.73. And if you look at the bottom Kaplan-Meier curve, the progression-free survival, you can see that it does delay progressions, but it first of all, it doesn't have, if you look at the Kaplan-Meier curve, there's a very steep drop-off. And so that very first criteria that it benefits most patients, we don't see with nivolumab monotherapy. And secondly, in terms of the durable responses, there are some patients that have durable responses, but as you notice, the tail of the curve it's not really there. It just keeps diminishing and dropping. And that can be highlighted even better with this longer term follow-up, the final follow-up. This was presented at GU-ASCO earlier this year. And as you can see, even looking out to this longer term period, again, this portion is highlighting that the majority of patients are not benefiting from the everolimus therapy nor the immune therapy. Most patients are having primary disease progression as their best response to treatment. But secondly, if you look for this tail of the curve, it never really flatlines. It just keeps dropping and dropping and dropping. And so there are some patients, even with nivolumab monotherapy, that can have very long responses. But I don't think the data really supports that we are curing anybody with nivolumab monotherapy. And the proportion of patients that are having these really durable, robust responses is arguably quite low. So that led to the development of Checkmate 214, which is a combination immune therapy trial. The combination is ipilimumab, a CTLA-4 inhibitor, and nivolumab, a PD-1 inhibitor. This was the primary endpoint was specifically in the IMDC intermediate and poor risk patients, although the trial did enroll favorable risk patients as well. But the primary endpoint was the responses seen in the intermediate and poor risk patients. This trial compared the combination of nivolumab and ipilimumab versus the standard of care at that time of a TKI, which in this case they picked sunitinib. It enrolled patients from 2014 through 2016, and the minimum follow-up was 30 months, and the co-primary endpoints were overall survival and progression-free survival. And as you can see from the top Kaplan-Meier curve, there was a significant improvement in overall survival with the combination. Interestingly, we still see this phenomenon, if you look at the bottom Kaplan-Meier curve, that there's a significant proportion of patients that have primary disease progression as their best response to therapy. Notably, though, it's fewer patients than with nivolumab monotherapy. Very interestingly, though, if we look at the tail of the curve, it really does look like we have a true tail of the curve where patients are out multiple years now and they're not having any disease progression. So this combination does appear to result in significant, robust responses that arguably could be potentially curative. And again, I'm showing you not the initial data from the New England publication, but if you'll notice, if you look at the x-axis, the time, this is the long-term follow-up, almost 5 years out, that was published in Lancet Oncology. Now, specifically, though, if you look at the favorable risk patients, there's no significant difference in terms of overall survival or arguably even with progression-free survival between combination immune therapy with ipi-nivo and sunitinib TKI monotherapy. And that's arguably, not arguably, but that's really just due to how well these patients do overall, just based on the biology of the disease. And you can see that in terms of the median overall survival hasn't been reached for either arm yet. These patients do really well with no matter what you give them. And you can see very few patients don't respond to any of these therapies. But also, interestingly, the tail of the curve is not particularly higher in the favorable risk group compared to the intermediate and poor risk group. But it's still there. The next first-line trial is the Keynote trial 426, which is the combination of axitinib and pembrolizumab. I don't have a lot of mechanistic studies in here just because of the, slides in here just because of the time constraints. But the hypothesis with this combination is that axitinib can introduce a lot of modifications to the immune system by altering T effector cells and T regulatory cells in the tumor microenvironment, and thereby creating synergistic action with checkpoint inhibitors such as pembrolizumab, a PD-1 axis inhibitor. So in this clinical trial, the combination was tested against, again, the standard first-line therapy at the time, sunitinib, at the same doses in the CheckMate 214 trial. Patients were enrolled from October 2014 to 2016, very, very contemporaneously, but almost slightly delayed compared to the CheckMate trial. About the same number of patients were randomized. The median follow-up at the time of this reporting is shorter, though, than the follow-up we have with CheckMate 214. The median follow-up was only 12.8 months. The co-primary endpoints are overall survival and progression-free survival. And notice this is in all patients, not just IMDC, intermediate, and poorest patients. And as you can see from the overall survival curve on the top, this combination was statistically superior to sunitinib monotherapy with a hazard ratio of 0.53. The progression-free survival was also significantly improved compared to sunitinib monotherapy. Notice we don't see a tail of the curve, but there's also a very small number of patients that have primary disease progression as their best response to therapy. And this last arrow is just highlighting that, again, based on this short follow-up we have of this combination, we're not really seeing a tail of the curve, but I will put out one caution that if you look at the median, it's progression-free survival. It hasn't been reached yet. Well, I mean, it's just barely at that point. And so there just might not be enough follow-up to really see the tail of the curve yet, just because the response rates are so high with this combination. If we look at the subgroup analysis of the Keynote 426 trial, based on clinical factors, including the IMDC risk category, all the patients seem to benefit from this treatment, including the favorable risk patients. They seem to benefit with the combination over sunitinib alone. So that is one distinct difference from this combination versus the CheckMate 214 trial. And then finally, the 9ER trial was just published, or presented, I should say, at ESMO just a few weeks ago. And this is looking at the combination of cabozantinib and nivolumab versus, again, the same standard first-line therapy of sunitinib. What I'm not showing you is the data of axitinib plus avelumab, and that's simply because of time constraints, and that trial does not have an overall survival advantage compared to the axitinib and pembrolizumab. So I'm just highlighting some key unique studies so that all show improved overall survival compared to sunitinib. So anyway, back to the 9ER trial. So again, all of these trials have the same control arm, sunitinib, same dosing, same schedule. 651 patients were randomized, a median follow-up of 18.1 months, and the primary endpoint is radiographic progression-free survival. So if you look in the top curve, I've switched them a little bit. So now PFS is in the top Kaplan-Meier curve simply because that's the primary endpoint. It's significantly improved progression-free survival compared to sunitinib with a hazard ratio of 0.51. A key secondary endpoint was overall survival, and it also significantly improved survival compared to sunitinib with a hazard ratio of 0.6. If you look at the beginning of the curves, there's very few patients that have primary disease progression. In fact, nobody had primary disease progression in this trial in the combination arm. If you look at the tail of the curve, it's with the short follow-up, it's hard to say, because once you finally start getting to 18 months, there's so few patients that are still in follow-up that it's difficult to say if we're really seeing a tail of the curve or not. But if you look from that 15 to almost 21 months, it does look like maybe we're starting to see a tail of the curve happen. So perhaps this combination, cabozantinib, just is the right TKI to partner with checkpoint inhibitors to truly result in high response rates, good tolerability, and durable responses. That being said, the follow-up isn't quite there yet for me to feel comfortable saying for sure it leads to a lot of these durable responses. But the Kaplan-Meier curve looks intriguing and provocative in that regard. Regarding subgroup analysis in the favorable risk group, so there did not seem to be any difference based on IMDC prognostic groups. So the favorable risk patients benefited more than sunitinib, as well as the IMDC intermediate and poor risk groups. And that is true regarding progression-free survival as well as overall survival. So how do I treat patients with metastatic RCC in the first-line setting? Well, for the IMDC intermediate and poorest patients, I prefer to use ipilimumab and nivolumab simply because of the long-term data demonstrating a clear, durable response and perhaps cure for a proportion of these patients. However, for those patients with rapidly progressive disease, I tend to start with a TKI-based therapy just because there can be this delayed response to the intermediate or to ipi-nivo, as well as there is that proportion of patients that don't benefit. For the favorable risk group, right now, my preferred therapy based on the data would be axitinib and pembrolizumab. However, cabozantinib and nivolumab is likely an option, although it's not yet approved. But it is important to highlight that any of these three combinations of, well, assuming the 9ER trial or combination gets approved, but any of these combinations are acceptable and appropriate. And it's really important to remember that all of this just highlights the fundamental key point that any combination is preferred over single agent therapy, except in rare circumstances. And one of those circumstances perhaps could be someone that has significant active autoimmune disease. So what is the future of immune therapy in renal cell carcinoma? Well, there's a number of interesting developments that are happening. For instance, in the Cosmic 313 trial, this is a phase 3 study that's estimated to have almost 700 patients, and it's looking at the triple combination of cabozantinib plus nivolumab and ipilimumab versus a standard of care of ipilimumab versus nivolumab. This is to see if the cabozantinib really adds any more synergy to the ipi-nivo combination, and this is a first-line trial. There's also the Contact 3 trial, which is a phase 3 trial, estimated to have about 500 patients, and it is looking at cabozantinib and atezolizumab versus cabozantinib specifically in the second-line setting after patients have already failed some other immune therapy. There is some data to suggest that this particular combination can salvage responses even in those patients whose tumor has become resistant to PD-1 axis inhibitors in the past. And there's a number of other, and those are really in the metastatic setting, but there's a lot of very interesting studies in the adjuvant and neoadjuvant setting. We await a whole slew of trials looking at monotherapy in the adjuvant setting with checkpoint inhibitors. Obviously, all the TKI studies were largely negative. But there's a very interesting study looking at nivolumab in the neoadjuvant setting, neoadjuvant plus adjuvant setting. And this is still enrolling and we actively await the results. And then there's also Checkmate 914, which is looking at multiple combinations of nivolumab versus ipi-nivo versus placebo in the adjuvant setting. This is also a phase 2 trial. So all of these checkpoint inhibitors are really starting to be tested earlier on in the disease process in the high-risk localized setting. Then there's also some novel combinations in the metastatic setting, such as the Pivot-09 trial, which is really bringing back some of this older data from the cytokine era, looking at pegylated interleukin-2 plus nivolumab versus the physician's choice of TKI, either sunitinib or cabozantinib. So there's a lot of very fascinating developments happening in the renal cell carcinoma space. So now let's pivot and in the last few minutes talk about immune therapy and prostate cancer. So does immune therapy work in prostate cancer? So Provenge was the first immune therapy tested in a phase 3 clinical trial to show benefit in prostate cancer. It's a dendritic vaccine stimulating APC, antigen-presenting cell, recognition of prostatic acid phosphatase, or PAP. It was first tested in 2006, and the approval came in 2010 because the results were unclear in that first trial, and so a couple of other subsequent confirmatory trials had to be conducted. And so that's why the delay was quite significant. So far, there's no other approved immune therapy trials, with the caveat of those patients that in a tissue agnostic way fit the criteria for pembrolizumab. So here's the dilemma of vaccine therapies. Now, these are two of those trials. The D9902A is that first trial in 2006, and then Impact in 2010 is one of those confirmatory trials. The publications don't have nice graphs for me to put up here, so I've for all of these things, so you can see I just put some text in those cases where it's not. But if you look at the PSA response rate, it's very low. So like 5%, right? So the majority of patients are not really seeming to benefit from this treatment, at least in terms of that measure. In terms of progression-free survival, again, we see this same, let me go back. We see that same steep drop of the curve where the majority of patients are having disease progression as their best response to therapy. And that's true for both of these studies. But intriguingly and oddly, there is an improvement in overall survival. So how can you have an improvement in PFS? Or how can you have no improvement in PFS, but still an improvement in overall survival? And looking at a sort of model of this, I think really helps me understand it. So if you look at the green line, and this is just some arbitrary cancer volume that's required to be achieved to have someone die from cancer-related problems. If you look at the blue line, again, this is a simplistic model, but let's assume that the cancer just grows in a linear fashion. And so over some period of time, whatever that time is, the cancer will grow sufficiently for that person to die. The data to me suggests that how Prevenge works is it doesn't cause tumor death per se in terms of gross tumor volume, but it does delay the growth curve. It slows it down. And so because you get this decrement in tumor velocity, then you can have no improvement in progression-free survival, but yet you can have this overall survival advantage. So are there molecular predictors of response of whose cancers are going to benefit more versus another? And so it has been tested, from those 3 clinical trials, molecular characteristics were evaluated. And there are some that do suggest patients are more likely to benefit. If you look at androgen-presenting cell activation, that didn't seem to make a difference between those that did have a better response versus those that did not. If you look at other things like the antigen itself expression, PA2024, which is this fusion protein of prostatic acid phosphatase plus GM-CSF, you do see that those patients whose tumor expresses it more have a better response to this therapy. Although it is important to know that none of these things are clinically testable today. This is just all research-based findings. And so in terms of molecular predictors, no, there's nothing in clinical practice that we can use today to help guide who may or may not be responding or could respond to this vaccine. Are there clinical predictors of response? So UCSF evaluated 94 consecutive patients, realizing this is a retrospective analysis. They identified 114 and excluded 20 for a few various reasons. And this was done from 2010 through 2016 with a reasonable follow-up of 2 years. The majority of their patients had ECOG 0, a healthy proportion had low Gleason scores, and most of them had a relatively low PSA, but did have a quite fast PSA doubling time. If you look at the median overall survival in terms of ECOG status, which is the one on the left, the majority of patients, or the patients that did better were those patients that had an ECOG of 0. Also, if you look at the PSA doubling time, The patients who had a slower PSA doubling time tended to benefit longer, which based on that model makes sense, because if Provenge decreases the rate by, say, this is an arbitrary number, but say if it cuts it by 50%, if your tumor growth rate is already very fast, then changing that 50% doesn't change a lot. But if it's growing relatively slowly, decreasing that by 50% makes a huge difference in terms of the time benefit that patients see. And finally, earlier seems to be better, as seen in the Kaplan-Meier curve number C. Those patients that had not yet received Abirenza did better compared to those that had Abirenza. I don't think there's any data to suggest that there's an interaction between the vaccine and Abirenza. I think it just has to do with the patients are earlier on in their disease process, and so there's more time to benefit from this decrease in tumor growth velocity. And finally, there's the Prostavac vaccine. This is a cancer vaccine with PSA as the tumor-associated antigen, and therefore it stimulates T-cell activity. It uses this dual prime boost idea, and it, in addition, has co-stimulatory molecules on it, 3 co-stimulatory molecules that are designed to prime and stimulate the immune system in general. But as you can see, there was absolutely no difference in this large phase 3 trial of 1,200 patients, or I say over 1,200 patients. There was no difference in the overall survival between any of these arms, any of these 3 arms, whether the patients received vaccine or vaccine plus GM-CSF or the placebo arm. There's a lot of, I guess I should go back here and say there's a lot of ideas and hypotheses about why this vaccine didn't work, including maybe now that it's being tested later, there's just so many more potent therapies that mild benefit that we see with vaccines is sort of masked now and not evident. But be that as it may, no one knows exactly sure why it didn't work. Maybe it's just not a potent enough vaccine, or it's the wrong antigen, but it didn't work. What about checkpoint inhibitors? So the pembrolizumab monotherapy, Keynote 199, in prostate cancer has a couple of different cohorts. So in cohort 1, it's PD-L1 positive. In cohort 2, it's PD-L1 negative. And cohort 3 is PD-L1 positive or negative, but they have bone-only disease, right? So they don't have RECIST measurable lesions, right? They don't have soft tissue disease that you can measure and evaluate for a change in size on CT scans. But cohorts 1 and 2 had to have RECIST measurable disease. So this enrolled patients from 2016 through 2017, and a reasonable number of patients were enrolled across the 3 cohorts. You can see the N for each of those columns at the very top. If you look at the waterfall plots in terms of overall response rates, there are some patients that have huge responses to these therapies, but it's very minimal. And if you look at these 3 different colors between cohorts 1, 2, and 3, there does not seem to be a consistent theme about PD-L1 predicting response to this treatment or not. If you look at the table on the right, you can see that a very small proportion of patients have an objective response rate, whether it's in the PD-L1 positive, negative, or bone predominant. The bone predominant doesn't have objective response rates, right, because you can't measure it. But if you look at PSA responses, again, fairly low in the 1 to 5% range. So what about so right now, there's no FDA approval for checkpoint inhibitors in prostate cancer, except for those patients that have MSI unstable disease. And pembrolizumab has a tissue agnostic indication for that, which coincidentally is only about roughly 2, maybe 5%, but probably around 2 to 3% of prostate adenocarcinoma. So future therapies, there's a clinical trial going on, Cosmic 021, specifically cohort 6, that looked at cabozantinib plus atezolizumab in testosterone suppression resistant prostate cancer or castration resistant prostate cancer. And if you look at the baseline demographics, there's a lot of patients have lymph node and bone involvement, but a reasonable number also had visceral disease like lung and liver that suggests more aggressive biology. A large proportion of these patients had docetaxel, prior docetaxel therapy, and all of them had novel hormonal therapies with Abirenza. If you look at the waterfall plots, this is strikingly different than pembrolizumab monotherapy. The majority of patients responded. There were a few complete responses, but very few patients had primary disease progression. In fact, in this cohort, only 4 of them had primary disease progression. And primary disease progression is defined as greater than a 20% rise of your measurable lesions. 20 to 30% is stable disease, and anything below that is partial or complete responses. If you look at the bar graph across the bottom, again, PD-L1 status did not seem to predict response. So in conclusion, we see that immune therapy works for prostate cancer. We are just in the process with lots of research trying to figure out how to make it work much better for prostate cancer. So getting back to our objectives, we learned that immune therapy leads to robust, durable responses in patients with metastatic clear cell renal carcinoma. Combination therapy is the recommended first-line treatment. The optimal first-line combination therapy is yet to be determined due to the relatively short follow-up of some of the TKI-based combinations, such as pembrolizumab and axitinib, and cabozantinib and nivolumab. And that short follow-up makes it difficult, really, to compare with the previous standard first-line combination of ipilimumab and nivolumab. Cures are possible in some patients with metastatic clear cell renal carcinoma treated with combination immune therapy. And there's, even if patients aren't cured, there's a greater proportion that do have durable responses. Switching to prostate cancer, vaccine-based immune therapy is modestly active in metastatic prostate cancer and has a role in treating some patients. And potentially more potent active immune therapy combinations are currently under development in prostate cancer and likely will be FDA approved in the near future. And the FDA approval for Provenge does not stipulate any specific patient or disease characteristics, but perhaps these slower growing cancers might be more responsive or have a greater benefit. So thank you for your time, and I'm grateful for all the patients that I have the privilege to treat, and for a number of funding agencies that help me with my ongoing research. And I'm happy to discuss any questions with you. Either you can send me an email or you can send me a Twitter. My handle is listed below. Thank you.